Hello, students. This is Dr. D. Just wanted to create a video regarding electronic health records and electronic medical records, really kind of tracking the progress from its inception to where we are today. And really, the first initiatives or uh, momentum towards electronic health records started in the Bush administration, uh, and that was really the initial foray of the federal government incentivizing providers to participate in capturing patient data in an electronic form. It really wasn't until 2010 and passage of the American Recovery and Reinvestment Act, ARRA, that was signed into law by President Barack Obama. There was a couple of um, acts inside of IRA, and the one that we're going to talk about today is the High Tech Act. And what that High Tech Act did was increase the monetary incentives for providers adopting electronic health records. So it did a couple of things. First of all, it established a certification process where vendors, software vendors, EMR vendors could bring their products to the marketplace, but they would have to go under a certification that was mandated by the federal government under the auspices of high tech. Once the vendor systems were certified, they were then made available to medical providers and hospitals. And so the incentive comes in at where the federal government, in some cases, offered as much as $66,000 for providers and hospitals that saw Medicaid patients, and up to $44,000 for providers that saw Medicare patients. Very important thing to note here that you could only pick one program, either the Medicare, which was $44,000 in total, or the Medicaid program, which was $66,000 in total. And what that did was reimburse medical providers and hospitals to offset the fees that it took to select the systems, implement the systems, and design the systems. But high tech didn't stop there. It took it a step further by creating the Meaningful Use Program, also known as MU. And over a 10-year period, MU was rolled out in three different phases. What I really want you to understand about meaningful use is it just didn't incentivize providers to uh, purchase an electronic record system, health records, or electronic medical record system, but it put mandates, metrics on the use or the quote unquote meaningful use of the technology. So there was certain clinical data that had to be captured for certain percentage of patients, such as vital signs, medical histories, medication list, and other types of clinical metrics for a large percentage of patients. Also, part of the mandates for meaningful use was electronic e-prescribing, using clinical decision support tools to enhance decision making processes, receiving laboratory results, radiology results, and other types of information electronically, as well as providing information electronically to the patient, such as care summaries, such as a patient portal, which is basically an electronic page, a private personal electronic page that providers and hospitals can push electronic information to the patient. And there was also some other requirements, such as being able to report to disease registries and other enhanced forms of communication. And so I invite you to look all about and learn all about the history of the Meaningful Use program. It's been since sunsetted in favor of a program called Promoting Interoperability. And we're going to talk about that in a second. But before we do that, I want to talk about these terms that we use synonymous with each other, which is electronic medical records, EMR, and electronic health records, EHR. At some point, there probably was a textbook distinction between the two terms, but today there really is no distinction. Uh, Both products are certified, if you will. Uh, and when we say certified, what we really mean is that they meet the standards for interoperability, meaning that each individual EMR system from each vendor has the ability to send and receive patient data in an electronic form. And usually that form is called a continuity of care document, CCD, or a continuity of care record. And there may be some more updated terms here. I think maybe the new term is CCD, which is clinical continuity of care document. Um, Now, one way that you can think about it is, let's say if we look at Kaiser Permanente, which is a huge health system, particularly west of the Mississippi, but I do know that they have locations on the East Coast as well. And so if you look at their system, and they're on the Epic system, they call it KP Health Connect. If you want to think about that as an electronic medical record, meaning that it's a closed loop system within an individual organization, that's one way that you can think of it. But you want to be careful, because just because we call it an EMR or an EHR, that's just really a way that we distinguish it. The functionality itself, uh, no matter which term we use, the functionality itself is the same for both. Whereas when we think about an electronic health record, we think about the ability for, let's say, Kaiser to send patient data or patient information outside of the Kaiser network to another hospital or another provider. And so when these terms were first established way back when, those were ways that we would think about, at least from a textbook perspective, how to distinguish an EMR from an EHR. But again, today there is no discernible difference, and we really use those terms synonymous with each other. So we talked about providers being incentivized by the federal government through the High Tech Act to not only select, implement, and adopt electronic health records, use them in a meaningful way, and then receive financial reimbursements as a result of your financial outlays. Again, $44,000 for those providers and hospitals that saw Medicare patients, and $66,000 for Medicaid patients. And there's two primary adoption models that emerged over that time. There was the phased approach and the Big Bang approach when we look at adoption models. So the phased approach is, well, we'll just go back to Kaiser as an example. Let's say here in Southern California, which is where I live, they have 25 locations. A phased approach would be, we would start with one location, switch them over from paper records to the electronic medical records. That process could take anywhere from 2 weeks to 2 months, depending on how large the um, location was. We would establish best practices after the go live, after the post go live. Then we would take those lessons learned or best practices and then move to the next location and then to the next location. Well, usually about 3 or 4 implementations under your belt, you've got the process down pretty much. And then it becomes just incorporating those best practices and following that model until you get the entire organization live. And that is the phased approach. But there is another approach called the Big Bang approach. And what the Big Bang approach says is that you flip the switch and everyone goes live all at the same time. So if we look at a hospital, for example, that is either switching from paper to electronic records, or today the big activity in the implementation EHR space are hospitals and providers switching from one system to another system, similar to the way that Kaiser switched from Cerner to Epic a couple of years ago. And that was a multi-million dollar changeover. And so, what we see with the Big Bang approach is every department in the hospital will go live all at the same time. And so, the day before everyone was on paper records, we come in that Monday morning or that Tuesday morning, we flip the switch, everyone goes live all at the same time. That's the Big Bang. We troubleshoot, we work them through the implementation, and at some point, 30 days or 60 days down the line, they are right back up to the same efficiency and capacity that they were before the implementation of the electronic health record. I think it's probably natural to understand that, at least initially, when you're moving from paper to electronic or from one system to the next system, you're going to experience a little slowdown when it comes to efficiency and when it comes to patient flow. But those hospitals that fully adopt, and when we say fully adopt, that means not having a hybrid system where some of your important information is still on paper and other important information is electronic. That's a hybrid system, or what we call a fragmented system. Full adoption is when you have upwards of 90% or more of that information electronically, and you are able then to capture the efficiencies and the synergies of your system. Uh, and so that is what a successful implementation, EHR implementation, looks like. And there's one thing in conclusion that I want to talk about, and that's really, what is this all for? When we can track the program back from 2010 with signing of the IRA, which included the High Tech Act. And really, we can even go back a few years before that when President George Bush actually started the process that's been since codified and since turned in to the Promoting Interoperability program. But what's the end game? What's the purpose? The purpose is for organizations to be learning organizations. What does that look like? You have patients coming into your health system presenting themselves. You are collecting data, informatics data on them, patient data, clinical data. And over time, in your EMR system, you have this huge database or knowledge base of patient information from interventions, pharmacological interventions, from procedures, histories, all of the above. Think of large health systems like Kaiser or other large health systems, United Health Systems, thousands, hundreds of thousands, and even millions of patient data in their database. Well, that becomes a knowledge base where you can then go and mind that system and extract best practices and procedures, best practices and interventions, best practices when it comes to pharmacological interventions. You then, the health system then takes that information, it codifies it, and it turns it into a policy and procedure or a care plan or a guideline for physicians and other medical and clinical professionals to follow. And that's the end goal of the federal government. That's the end goal of the adoption of electronic health records and all of the collection of demographic and clinical data and other types of data. It is for health systems to turn into learning organizations. That way, in the future, when a patient walks in, African American male between the ages of 45 and 55, presenting with A, B, and C. Here's the best practice care plan. Here's the policy and procedure for the intervention. Where did that information come from? It came from you extracting those best practices from your database. That is really the beginning of evidence based medicine internally. And then when we look externally to see what the other players in the marketplace are doing, we incorporate that into the clinical workflows and into the care plans. And then we are really starting to incorporate more of an evidence based practice and an evidence based medicine, evidence based interventions into the system. And then the final thing we'll talk about here is this whole idea of interoperability. And really, what I want you to know about interoperability is that it already exists. You're already familiar with it. We just don't have it in healthcare. So when you pull up your app for your bank and you transfer money to someone or you pay a bill from your phone or from any other type of device, when you're on your social media and you're able to send pictures and send messages via Facebook, via Instagram, that's interoperability. That's and what interoperability is the ability for quote unquote man and machine, we'll say human and machine, to send, receive, exchange information while preserving the original form, the original content, and the original meaning. Of course, we've had that in banking forever. Seems like we have that in social media from day one, but we're still struggling in the healthcare space. One of the reasons why is because of past legislation like HIPAA that was passed in 1996, signed into law by President Bill Clinton. And those types of privacy and security concerns really tightened down the industry, and it didn't promote the free sharing of patient data because there was always a fear of violating HIPAA and having to face fines and sometimes even jail time. Well, kind of fast forward now till today, the modern environment where the federal government is creating all of these laws like the freedom of information, the data sharing, the promoting interoperability to promote the free flow of data being exchanged between providers and hospitals. And so, uh, more to come as it relates to electronic health records and electronic medical records. But remember, the end game is interoperability throughout the entire industry. And as a result of having that free flowing data, each organization becomes a learning organization able to extract best practices and interventions from their own knowledge bases in their efforts and pursuits to practice evidence based medicine.